So I will open the floor. I mean, we will have a Q&A about ALL, and I would ask also Dr. Gokbajit to be with us and unmute her mic. And so I would like to remind the attendees, kindly write your question in the Ask Question tab. So the first question I have, I can maybe address it to Dr. Nicola. How do you deal with, how do you test for MRD using the flow cytometry in a patient who is post-blinatumomab, specifically for CD19 as a basic gating?
Okay, that's a very good question, but I'm probably not the right person to answer it, because there are some insecurities about the flow cytometric MRD testing, and this is the reason why in Germany we solely use the PCR method. And but I think the leukemia-specific panels after immunotherapy with blinatumomab should, of course, consider that CD19 is not the marker which should be included in the leukemia-specific subtype. There, because of the loss, which occurs less frequently than in the CAR T-cell setting, but still some of the patients treated with blinatumomab, around 20%, lose the CD19 on the surface at a further relapse. So for this and other reasons, we still prefer the PCR for MRD testing.
Okay, thank you. Another question, I will address it to Dr. Stock. Are you using any targeted therapies post allogeneic bone marrow transplant as a maintenance, like blinatumomab maintenance or inotuzumab maintenance?
Yeah, that's a really interesting question. At our center, we are not using that approach, but there have been some, there have been a couple of sort of posters anyway that I've seen on the use of blinatumomab anyway, post-transplant, to try to eradicate MRD in those patients who are still MRD positive. So, and that was a poster that was presented last year at ASH from the MD Anderson group. It didn't look so promising, but again, these patients were still MRD positive post-transplant, and it was difficult in those patients to eradicate MRD, perhaps because by the time blinatumomab was instituted, it was already, the disease burden was already getting too high. But it is an interesting idea. It's just that, of course, post-transplant, the use of inotuzumab might be quite worrisome with the risk of veno-occlusive disease. And the use of blinatumomab, while feasible, is not the easiest drug to administer simply because of its infusion in patients who have just finished prolonged therapeutic course. But I don't know of any frontline trials in a randomized fashion that is looking at that in patients with ALL, MRD positive or MRD negative. Perhaps, Nicola, I don't know if there's anything going on in Europe in that setting.
So in the trial which I've shown you with blinatumomab and the MRD testing, we plan to include patients post-transplant. But unfortunately, it doesn't work. So unfortunately, the transplanters do not consider this option. First of all, they reduce the immunosuppression, and then they think about DLI. I think it would be worth a try to use blinatumomab, and but not very early after transplant, maybe because you need active T cells for the activity of this compound, and very early after the transplant, this may be a problem. So yeah, there's also a trial ongoing with combination of DLI and blinatumomab. It could also be interesting.
Yeah,
but it recruits very slowly. As you said, the problems are there are a lot of problems in the transplanted patients.
Yeah, it's hard, and that study from MD Anderson, again, I think it was a combination of either waiting too long because you wanted the T cells present, or the fact that there were no T cells because the immunosuppression was still present. Exactly, it's confounding. But it is a reasonable question. Are you testing that at all in Saudi Arabia?
No, actually, we are not. Although I mean, some colleagues actually raised this based on the posters that you mentioned. Okay, so the other question I have, this to Dr. Gokbajit, is regarding the upper age limit for CAR T-cell and ALL. Are we expecting an increase on the upper age limit? I mean, currently it's at 25.
Yeah, I think that is really a big problem that the CAR T cells end at this age. So it is totally unacceptable. But we have to accept this because the trial was designed in this way. I would certainly think that we need the CAR T cells also in older patients, and there are some ongoing trials from Kite, for example, which may help that we get another product for the patient population older than 35. But I don't see a lot of data for the adult population, so real older patients. So I think we would have to wait for tolerability data, for example. But I am quite confident that the upper age limit would be increased. Currently in Germany, we cannot use a CAR T cell if the patient is 26 years old. Done.
Same with us. But we heard that the Kite product is supposed to be approved very soon. That's what we've been hearing, but we don't know that.
In the same line with the CAR T cell, are you using it as a first line for the salvage or relapse, or after second line of treatment?
Well, in the United States, I mean, I think probably everywhere, the trials are mostly for second line or not even second line treatment. It's certainly not in the front line. Although I have to say that our pediatric group, the children's oncology group, does have in their frontline trial now. At the end, if there's still MRD positivity, patients then get CAR T cell, can have a CAR T cell implemented. But that's, again, the pediatric population where the CAR T cell has already been approved for the relapse. But in our trials, it's mostly second relapse where the CAR T cell product is being tested, not even in first relapse.
Yeah. Same for Germany. So it is also the marketing authorization is not for first relapse, and because of the high price, our insurance companies do not accept any deviation.
Okay. Another question is regarding Down syndromes with ALL. How would you consolidate treatment? Transplant, chemo, targeted therapy, CAR T cell? We'll start with Dr. Wendy.
Well, I actually have very limited experience myself in the adult population, but the pediatricians now have published a number of studies recently showing equally good outcomes for the patients with Down syndrome, ALL, using these pediatric approaches. Of course, they're modified to avoid the high-dose methotrexate and are using more of the Capezi, the intermediate dose methotrexate with the asparaginase. But they've gotten very, very excellent outcomes for those patients. And while we don't have any exclusions on our adult trials for enrollment of Down syndrome patients, we have very, very few of them. So I really don't know how to comment on the use of this in the older adult or the young adult Down syndrome population. How about you, Nicola?
So yeah, we collect this information in our registry. We have a few patients as well, maybe 10 or 15 all over Germany. And as the pediatricians, we recommend to use the standard regimen, maybe reducing the daunorubicin in the induction also, and of course, check the potential cardiac complications in these patients and reduce the methotrexate. And if the patients remain MRD positive, they will receive also blinatumomab and try to transplant them. Yeah. So we try the same as in the non-Down syndrome patients with some modifications.
Thank you. So I have another question regarding the T cell ALL in CR1. How would you stratify the consolidation? Is it based on MRD?
Yes. We approach them in the exact same way as we do the as the B-ALL patients. However, unfortunately, we don't have a blinatumomab or an inotuzumab at this moment, but it looks very promising, the addition of nelarabine and in the frontline setting, which we've adopted at our own center for the patients with TALL who seem to tolerate the schedule quite well. But there are some interesting data on the addition of some of the BCL targeting agents, particularly venetoclax, in the frontline, in the relapse setting, excuse me, that we're going to think about bringing forward to these patients. But in terms of stratification, we do exactly the same. How about you?
Me?
So
yeah, or you, either.
Yeah,
I'm just curious.
So we have integrated nelarabine in the first-line treatment as consolidation also, and also in patients who remain MRD positive. So this is our blinatumomab in TALL, although it works less good, as I must admit. In addition, we have a rather poor outcome in patients with immature early TALL, and therefore these patients are, in our protocols, candidates for stem cell transplantation.
Yeah, I think that population is such a tough one in terms of what to know what to do, because the pediatric data show that if MRD is eradicated, which it seems to be in these ETP patients, they do just as well, as I showed on that one slide. But my own personal experience has not been quite so favorable, even with MRD negativity. And perhaps that's the sensitivity of the MRD testing that we use, and we now use a more sensitive test. But I agree that this is a high-risk subset and can be transplant candidates.
Okay, thank you so much, Professor Cook-Budget and Professor Stuck, for very informative talks and deliberation on the questions and answers.